sharing experiences, really important, learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scanner.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a positive gene change in some people.
Good afternoon. My name is Tracey Keteepe-Arachi. I'm a cardiologist at the John Radcliffe in Oxford in inherited cardiac conditions. I'm not a gynaecologist. I know that this was posted as women's health, just to clarify that. And so I'll be talking to you about heart health in females, in women. My focus is mainly on coronary disease and ischemic heart disease, because obviously, despite the fact that cardiomyopathy is clearly diagnosed probably in many of you, you are still potentially susceptible to having coronary disease and ischemic heart disease as well. So it's certainly relevant. I don't have any disclosures. I'll start by talking about these three ladies, and I think it is pertinent because we've had many female cardiologists over the years who have made a huge difference to the lives of many patients and children. So the first lady is Myra Logan, who is the first African-American cardiac surgeon to do successful open heart surgery. The second lady is Maud Abbott, who is the very first medical student in Canada, and she fought tooth and nail for her place there. And she was an expert in congenital heart disease. And then, of course, the infamous Helen Taussig, who was, again, American, but made a huge difference in congenital heart disease and saved the lives of many children. So I know it's probably not politically correct these days to say it, but women are different to men, fundamentally. And we can see that anatomically. So we know we start off in childhood relatively similar, say, in terms of the cardiac size. And then during adolescence, boys go through a huge growth spurt when it comes to the cardiac size, and girls tend not to. But we know that does affect the functionality of the heart, and that actually, despite women having smaller heart sizes, they do have stronger ventricular contractility. So the left ventricle, big pumping chamber of the heart, contracts more strongly. They have smaller blood vessels, and that has implications when it comes to coronary disease and furring up of those small blood vessels, and a smaller overall blood volume within the circulation. It is gradually coming to the fore in terms of increasing awareness in the public domain, but we do need to increase awareness within medicine as well, and I'll talk about that a little bit more. And sadly, you know, things like this happening, this lady's face is probably familiar to many of you, Emma Chambers, an actress who was in Notting Hill and the Vicar of Dibley, closet Vicar of Dibley fan. And she died at the age of 53 from a heart attack. And she was otherwise relatively, I think she had allergies. But other than that, was relatively well, and there wasn't any warning. So it does happen to women. Just to reiterate that point, this is looking at the cause of death in men and women in Europe. And you can see that coronary heart disease, 19% of men died from coronary heart disease and 20% of women. So it is a real thing. When I was initially writing this talk, I was going to say, breast cancer, it does kill women, obviously, but actually heart disease kills more women than all of the cancers put together, not just breast cancer. And I was really shocked by that. And I don't think many people know that. And yet, you know, with regard to breast cancer, it's amazing that there is such huge awareness. The pink ribbons, you know, Macmillan, it's out there. People know about it. You know to check your breasts. When it comes to cardiac disease and cardiovascular disease, I don't think we have the same level of awareness out there in the public domain, and that's a problem. The Lancet Commission published the first document of its kind in 2021, saying that cardiovascular disease was responsible for 35% of the total deaths in women in 2019, and that's on a global scale. Huge. So are women being underserved? Well, the short answer is yes, they are. This was a study that was published, huge nationwide cohort study in England and Wales, and they looked at how women and men are treated when they have heart attacks, and they actually estimated that over 8,000 deaths in women who were hospitalised with a heart attack could potentially have been prevented if they were treated in the same way as their male counterparts. Now, those 8,000 women are sisters, daughters, mothers, and their deaths could have been prevented because they didn't have the same quality of care that their male counterparts had. And to my mind, that's unacceptable. So I'm going to move on to what the differences are between men and women and how is this happening? What's going wrong? So I'm sure many of you are familiar with the sort of routine characteristic risk factors that we talk about in cardiology. So smoking, cholesterol, blood pressure. But we actually know that in women, risk factors are not kind of treated equally. And a lot of these characteristic risk factors actually have more weight when it comes to women. So if you are a female who smokes, actually your risk of having a heart attack or having cardiovascular disease is 25% higher than a man who smokes. Unfair, isn't it? Same with cholesterol, same with high blood pressure, and diabetes is particularly potent when it comes to women. Your risk of cardiac disease is 44% greater in a woman with diabetes compared to a man with diabetes, and you're 29% greater risk of having a heart attack compared to a man with diabetes. And there have been lots of studies to show that actually women have power. We can change the course of our risk factors, and we can actually change the way we live, and we can reduce the risk of having heart attacks by more than 80% if we're able to stop smoking, eat more healthily, maintain our weight, etc., and get our blood pressure under control. So the impact of risk modification is far greater in women, and that's what health professionals really need to be pushing in our female patients. So moving on from the normal risk factors that we talk about, there are risk factors that are specific to women. We talk about the menopause. I'll go on to talk about that a little bit more. Risk factors that occur in pregnancy are also very important. Polycystic ovaries, that disease is quite potent. About 10% of the population, the female population, childbearing age, have PCOS, and it's associated with higher body mass index, it's associated with higher blood pressure, diabetes. So it ties in very well to those characteristic risk factors. I think I quite like this slide because actually it shows us that we need to be thinking about things really early on in a woman's life, because there are things like depression, for example, starting your period early, autoimmune diseases that have an effect on cardiac risk, and those start quite early on in teens, 20s. We don't really think of women at that age as being at risk of heart disease, but these are cumulative risks. So as they go through life, the risk will get greater and greater. And then women of childbearing age, again, don't really think of women of childbearing age as being at risk of cardiac disease, but actually there are certain things that occur during pregnancy that really we should be using to predict risk. So things like high blood pressure during pregnancy, gestational diabetes. It means that you're more likely to go on to develop diabetes later in life. Any problems with your placenta has been shown to increase your risk of cardiovascular disease going forward. And then probably more characteristic in later life, so premature ovarian failure just means going through the menopause early. And I'll touch on the menopause and how that affects cardiovascular risk. So just to touch on pregnancy, as I've mentioned, high blood pressure, gestational hypertensive disorder is just high blood pressure during pregnancy. Many of you will have heard of preeclampsia, and that actually doubles your risk of cardiovascular disease. So I feel that women who have preeclampsia, they go off, they have their babies, have a nice life. We don't see them again. They certainly don't come back to cardiology clinic, that's for sure. And actually we're sending these women off into the ether with double the risk of cardiovascular disease. It seems silly. Gestational diabetes, as I mentioned, greater risk of developing diabetes, and we know that it's a very potent risk factor in women. And preterm delivery has also been associated with increased cardiovascular risk, not in the child, but in the mum. So we need far more research into what happens in pregnancies. The menopause, so transitioning into the menopause actually accelerates a woman's risk. So estrogen is actually very protective against cardiovascular disease. It acts directly on the sort of lining of your blood vessel. So it helps the muscle of the blood vessel to stay nice and soft and relaxed. And it also prevents any build-up of cholesterol plaques and atherosclerosis. So it prevents that furring up from happening. What happens when you hit the menopause? Well, you take away that estrogen and that protection, and so your risk of cardiac disease as a female goes up very, very rapidly, and it becomes equal to that of an age-matched male. So a big change there. Aside from that, some of you might know that when you reach the menopause, you have a change in the way that your body composition is, so actually change in fat distribution, more likely to put fat on around the middle, which is a cardiac risk factor. Visceral fat deposition just means you get fat around your organs, again related to cardiovascular risk. Increase in body weight, more likely to develop diabetes, high blood pressure, and a change in the way your cholesterol is also. Controversial hormone replacement therapy. I've had quite a few women coming to clinic saying, I'm perimenopausal, I'm having really intrusive symptoms. A lot of the time it's psychological symptoms, depression, anxiety, brain fog, and I can't get HRT. I'm not allowed it. I'm told I'm not going to be prescribed it. And I ask them why, and say, well, I've got a heart condition. It's like, well, that's not a reason to not have it, actually. Of course, it should be discussed with your primary care physician, but actually just saying, oh, you've got a heart condition, that's not a reason to not have HRT and to suffer in silence, because the menopause is hard, actually, and there are things out there that we can give our patients to make their lives better, and why are we not doing that? The Women's Health Initiative, which is the initial study that a lot of the guidance was based on, initially came out saying, no, we mustn't be giving HRT to women. It increases cardiac risk. Actually, when they went back to the data, reanalyzed it, they came up with this timing hypothesis that actually said that HRT may well be protective against cardiac disease. So the timing is important. When you initiate HRT, it needs to be within 10 years of the menopause, and the woman needs to be under the age of 60 to actually recoup all of that cardiovascular benefit. But again, more research required. So I just want to touch on psychosocial risk factors, because this really affects all aspects of health and well-being. We know that this problem affects women more commonly than men. Women are more likely to be victims of domestic abuse than men, and it has indirect and direct implications. So if you're under chronic stress, you're more likely, well, you're twice as likely to have a coronary event, research has shown, and that's sort of everyday stress. the indirect implications are that actually these individuals who are under stress will modify their health behaviours. They're more likely to smoke, they're more likely to have a poor diet, they're less likely to seek medical attention if they have symptoms, and when they do, it's going to be much later in the disease progression. And so they're going to have a worse sort of pathology, if you like, that's harder to treat, so their outcomes are not going to be as good. So this knock-on effect is really important. And I've started asking patients about what's stressing them out in clinic, but I think research showed about 3% of cardiologists actually ask patients if they're under any stress or have any anxiety in their lives. So it's a really small number. We tend to focus on our system, which is the heart. Have you got any chest pain? Have you got any shortness of breath? We don't go, what's happening for you in your life? Is there anything we can do to make this better? Do you want to just talk about it? Depression and anxiety, there's an epidemic at the moment. We know that's an independent risk factor for cardiovascular disease, almost as potent as smoking in some studies. So really important that we treat this, that we identify it actually. Many research studies have shown that people with depression and anxiety will have worse outcomes with cardiovascular disease. And as I mentioned, it's not routinely screened for in cardiology clinics. So with that in mind, one thing that I found myself recommending to patients, and I hope you don't find this too woo-woo, is an app called Headspace. Has anyone heard of Headspace? Yeah. So years ago, meditation, people were like, what's a doctor recommending to me? But actually, I've had patients come back to clinic and say, oh my goodness, this has helped me so much. And I'm going to just take 5 minutes out, if that's okay. And if one person goes home today and downloads I don't have shares in the app. I'm just going to see if this works, because I'm going to hopefully play this for you. Is it going to play? The audio.
We're going to start with the eyes open. Just a nice soft focus. Aware of the space around you. Just taking a couple of big deep breaths. Breathing in through the nose and out through the mouth. As you breathe in, feeling the body expand. As you breathe out, noticing how the body softens. And with the next out breath, just gently closing the eyes. As you close the eyes, just taking a moment to pause, to appreciate that feeling of being on your own for just a few moments. Nothing to do, just feeling the weight of the body pressing down. Appreciating that sense of space. And just starting to notice the environment around you, just allowing any sounds to come and go. Allowing any thoughts to come and go. And then bringing the attention back to the body. Just taking a moment to notice how the body feels. Sense of heaviness or lightness. Sense of stillness or movement. Not thinking about the feeling, just noticing and then just letting it go. Instead, shifting the attention to the breath, a rising and falling movement in the body. Starting to notice the rhythm of breathing. Can't feel any movement, just gently placing your hand on the stomach. And although we're following both the in-breath and the out-breath, paying special attention to the out-breath. As you breathe out, just letting go of any inner chatter, letting go of any tension in the body. And in letting go, just feeling a sense of space. In the mind, in the body. Not breathing in any special way, just following the body as it exhales. Enjoying that feeling, appreciating that feeling of space with each and every out-breath. As you begin to bring the attention back to the body again, just coming back to that feeling of contact, body pressing down. Back to any sounds around you. And when you're ready, just gently opening the eyes again.
Okay. Well, I hope you're all feeling nice and relaxed now. So the reason why I really believe in meditation, actually, there is research behind it, and MRI scans have shown that meditation can actually shrink your amygdala, which is the part of the brain that is sort of your stress center, your fight or flight center. When you get really anxious, that's your amygdala firing. And yes, brain MRI has shown that people who meditate can actually shrink it. So they did them before they meditate, and they measured the size of them, and they made them meditate for 6 weeks, and then they did another MRI and it had shrunk. So there is research behind it. But anyway, I hope it just makes you feel nice. So yes. So moving on to how men and women differ. So symptoms of cardiovascular disease. Now, women often present with chest pain and the characteristic symptoms that we've been taught in medical school, really, sort of central crushing chest pain radiating to the arm, and the patient comes in literally clutching their chest. Now, all of that was really based on studies that were done in men, white men. And so we know actually that ethnic minorities present in a different way and women present in a different way. And while they might still have chest pain, they're more likely to present with 3 or more greater symptoms like extreme fatigue, so disproportionate tiredness, lightheadedness, pain elsewhere, pain in the upper back, feelings of heartburn or indigestion or tingling in the fingers. So the relevance of this is that it somewhat muddies the waters when we've been taught that, no, you must present with central crushing chest pain, and women don't present like this. And it often delays diagnosis. It causes misdiagnosis. And if there is any delay in diagnosing a cardiac problem, then you are more likely to have a worse outcome. We also know that quite frequently women are dismissed when they go to their physician with symptoms, and I'm sure many of you in the room may have had this happen to you, where you've presented with symptoms and you've been told, no, you're having an anxiety attack, or it's definitely not your heart, and actually we know that we really need to start investing time and effort in educating healthcare providers. So that is important. I'm not going to go into too much detail when it comes to these quite busy slide, but it's really showed there's a huge study of about 7 million heart attack patients, and they divided them into men and women, and they looked at how they were treated. And really the take-home message from this slide is that women had worse outcomes. Now, the authors obviously highlighted the fact that the women tended to present at an older age, on average about 7 years older, with more comorbidity, so with other things wrong with them as well, which obviously will affect how well you do. But interestingly, they did find that fewer of these individuals, fewer women, were referred for invasive management of their heart attack. So they didn't go to the cath lab and have a stent put in compared to men. And as a result of that, their outcomes were likely to be not as good as the male cohort. I'm a bit stuck there. Another large study in Australia, they looked at acute chest pain. So this could be a heart attack, this could be asthma, this could be musculoskeletal pain. And they actually looked at how women were treated pre-hospitally, which is interesting. And what they found was that women were less likely to be taken to hospital. They were less likely to have a cannula, a line put in. They were less likely to have an ECG done. Now, in this country, an ECG, I think it costs about 30 quid. So there's not really any reason to not do an ECG. But we know that this is happening and it needs to be addressed. So should we have sex-specific treatment? Should women have different parameters to go by compared to men? Well, probably yes, but there's also been some research into this, and actually what's been found in a recent study was that they changed the parameters that they use for a test called the troponin, which is how we diagnose heart attack. So if it's over a certain threshold, you've had a heart attack. That's a simple way of thinking of it. So they lowered that threshold in women, and they diagnosed 5 times as many heart attacks in women. Oh my goodness. So we're diagnosing lots of heart attacks. So women are going to be diagnosed, they're going to be treated, they're going to have better outcomes now because we're actually making sure that we're catching all these women who are having heart attacks. No, that's not what happened. There was a marginal improvement, but not to the degree that you might have expected. And it became clear that having diagnostic accuracy and being able to diagnose heart attacks didn't actually sort out the problem that was an attitudinal issue. People, healthcare professionals, sometimes don't believe women when they even have the biochemical proof that they're having a heart attack. It's incredible. So there are other factors at play. Just wanted to bring this up, and probably all of you are familiar with this, just to highlight the fact that, there it is, sex is coming into these factors as well, and we do need more research. It's happening. There are papers now relating to cardiomyopathy. Not enough, but it is a work in progress. This is Paz Tile from the Brompton. Again, many of you will be familiar. She's done this groundbreaking research into dilated cardiomyopathy and looking at, is it more common in males or females? It's actually more common in males, gene positive and gene negative. And women tend to present with more sort of mild disease, but for some reason have more complications. And we're not currently clear as to why that is. And there are lots of things that are hypothesized, whether it's misdiagnoses, delayed diagnosis, as I've mentioned, or is it just down to physiological differences that we now are aware of? So I'm just going to touch on this. Again, many of you will be aware that the prevalence of hypertrophic cardiomyopathy is greater in men. Women tend to be diagnosed at an older age with an average difference of about 10 years, and they tend to be more symptomatic, going on to have more complications actually of things like heart failure, stroke and atrial fibrillation. They're more likely to have obstructive disease. Again, that could be an anatomical phenomenon because we have smaller hearts in women, and an increase in adverse events post-menopause. So again, it's not clear as to perhaps there is an effect of estrogen even in cardiomyopathy patients. But the theme going forward really in all of these studies is that women are underrepresented in research. I'm going to scoot over that. And that there are also sex-specific cardiomyopathies. I think you've had a talk on Takotsubo today, predominantly affecting women, peripartum cardiomyopathy, obviously exclusively affecting women. There's a stand outside. These types of cardiac problems that primarily affect women, there needs to be more research into these also, because why is that? So how to overcome this? We've talked about a few of these factors on this slide, and we know that research is one part of how we're going to overcome this. My personal feeling is that education is pivotal, and I think you get probably actually the most bang for your buck in educating women, the general public, patients, but also healthcare professionals, because I don't think that there's enough of that happens actually. And at the John Radcliffe, we performed a questionnaire as a quality improvement study actually, and one of the questions was asking women who were sat in the cardiac outpatients department, so they're there for some sort of heart issue, and we said, what do you think the biggest cause of death is in men? And they did us proud. About 2/3, just over, said heart disease. Great, you've got it. What's the biggest cause of death in women? Well, about 1/3 of them said heart disease, but almost 1/3 also said breast cancer. And actually, remember I said, actually, you know, all of the cancers put together cause fewer deaths than heart disease in women. So there is quite a disproportionate view of this, and I think we do need to, you know, raise awareness in the general public. We need a ribbon. Underrepresentation in research continues to be an issue. I've touched on this before. So many years ago, there was a blanket exclusion of women of childbearing age. And if you think that sort of goes from your teens up until you're probably about 50. So it's quite a number of years. And then many studies would have cut-offs for age. So say the cut-off 70. Well, many women have their heart attacks after the age of 70 because they present later than men. And so you're not going to catch all of those women, which is a real shame. And then there would be body weight limits, sort of any excuse to not have women, because what researchers wanted a long time ago is a very homogenous population of white men, actually. And so what we really need is a change in this attitude. And I think it is happening. As I was saying to Matthew, it's like turning the Titanic. It's taking a while to do, but we are turning, I think. And as I said, there is progress. So this is a consensus statement. It is, we are educating our healthcare professionals as well, that we need to change the way that research is being done. I'm going to, as a closet Vicar of Dibley fan, I saw them putting the Christmas tree up, the decorations like that, so I'm not going to be too hard on myself. Is this going to...
If you're a content creator and you're not using Kajabi, you're leaving money on the table.
Using YouTube. Oh. Skip. Is it going to do it?
Make it take it.
I'm trying to skip. Yeah. I'm clicking it. It's not wanting to work. Oh. There we go.
Right, little Christmas gadget for you.
Great.
Santa Claus goes to the doctor with a problem.
Oh dear.
Yeah. He says, Doctor, I think I've got a mince pie stuck at my bottom.
I wonder how that got there.
Don't go there, okay? So the doctor says, okay, Mr. Claus, bend over, please. And he looks, and he says, yes, indeed, you do have a mince pie stuck up your bottom. But you're in luck, because I've got some cream for that.
It's the only vaguely medical one I could find. Apologies. Oh, we don't want it again. So I'm very happy to take questions.
Hello there. Thank you for your really interesting talk. I was interested when you were talking about pregnancy and hypertensive disorders of pregnancy, preeclampsia and everything, and the lack of follow-up for women after having these conditions in pregnancy. And I know, there are some clinics, there are some, pregnancy hypertension clinics in some big hospitals where they get followed up, but probably only for a short time. Do you think that these women, what do we need to be doing with them? How do we need to be following women up, and how do we, keep a closer eye on people who do present with these, complications in pregnancy?
Yeah, I mean, it's the age-old conundrum of being in a system with limited resources, and trying to balance that with preventative care of patients. And I think that's where we should be going with medicine, really, is preventing problems, because, it just doesn't make sense, even from a health economics perspective, that we're allowing people to go on to have heart attacks when we know that they're at risk. In a practical sense, I feel that we should be seeing these women probably at least every 5 years, I would say, to check in. And whether, I don't think primary care has capacity for that. I'm sure the NHS does not have funding for that or resources for that. But I think we need to be able to catch these people before it's happening. We need to be able to see these women and go, okay, you had preeclampsia, so we know that you've got a risk factor. What's your cholesterol? What's your blood pressure doing now? Are you hypertensive now? Because obviously, hypertension, you very rarely get any symptoms. So are they wandering around with horrendous blood pressures? Psychosocially. So we need to be attacking all of their risk factors, because we know they've started not on a level playing field.
We know we need to.
Yes.
And it would be great to be able to, but how do we do that? Do they come to cardiology? Do they?
Yeah, well, I think probably, yes, they do need to come to cardiology, but I think this is where research plays a real role, is because we need to be able to translate data, and we need to be able to show very clearly, say, yes, you're twice as likely to have a heart attack, but we need more data to really, that's how things happen. It's like, is this actually happening to women? Yes, it is. Okay, right, we need to do something about this. But the problem is that you have your baby and then you'll have your heart attack 20 years later.
Yeah,
so
that's
actually,
the trouble,
no one makes the connection.
It's the gap. Yeah, fill in the gap.
Yeah.
In that time period. Thank you.
Thank you.
Thank you. I know with menopause in ladies without cardiomyopathy, they can experience things like palpitations. So for the arrhythmogenic cardiomyopathy population, is it recognised that this can increase and cause further complications during the perimenopausal period?
So is your question that the menopause can give you more symptoms?
Yeah, so, for a healthy
cardiomyopathy
person, they may experience palpitations. If that's your daily life as somebody who suffers with a high burden of arrhythmia, is it recognised? Because I certainly know I have arrhythmogenic cardiomyopathy, a lot of my friends, but it's something that we've all said, yeah, God, it gets really bad in that week before the period. It really goes crazy, and, palpitations go into overdrive, but it's just, I could time my shocks to my cycle, but it doesn't seem to be sort of recognised, or is that even a thing that's looked into or considered? Because equally, if we're being obstructed from accessing HRT because of this misconception of heart disease, actually that could solve a lot of or prevent a lot of the interventions that are being done.
Yeah, I mean, that's a brilliant question. I mean, even women who don't have cardiomyopathy report changes in symptoms of palpitation around their cycle. And it is increasingly being recognised, but again, there needs to be more research. I think you're absolutely right. HRT for many women is a real, and I'm not saying this flippantly, is a lifesaver. There are women who have taken their own lives as a result of going through the menopause, which is just incredibly shocking and sad. And actually, there definitely needs to be a real push, which I'm hopefully getting involved in, to give women HRT, women with cardiomyopathy HRT. And it would be so interesting to see what happens to those symptoms once they're on it.
There's a gentleman just behind you.
Hello there. You were mentioning that cardiovascular disease is prominent in women, but yet not particularly recognised. As a health professional working in cardiac rehabilitation, we see predominantly men in cardiac rehabilitation and not women. So do you feel that there's still a lack of education with health professionals post-diagnosis, post-intervention, and cardiac rehabilitation being a rehabilitation program for patients with heart attacks, 6 to 8 weeks of a program?
Yeah, absolutely. The short answer is yes, and there's plenty of research to show that fewer women are referred for cardiac rehab, actually. And so I think the problem with the whole system is that it falls down at every point, from awareness to symptoms to diagnosis to treatment to, you know, what meds we put women with. Are less likely to get aspirin, for example. I mean, and then it goes on to cardiac rehab. And I think we really need to be pushing for every stage to be addressed.
Just as a follow-up question, sorry, do you think there should be a women-specific cardiac rehabilitation?
In an ideal world, yes.
Thank you. Thank you.
Hi. So obviously there's a lot of preemptive things that women can do to prevent things like cervical cancer, or like, you know, you can get pap smear, etc. Do you have any advice for women to do on a certain cadence? Like, what do we ask our doctors for? Like, how do we prevent? Like, can we say we want to get a regular ECG, or what is it that we can do?
Yeah, I mean, it's very difficult because, you know, for cervical cancer, there's a very clear screening program. It's cost efficient. And while ECGs are relatively cheap, I think if all women went to their GP and asked for an ECG, the system would probably collapse. What I do say to my patients is that if you have symptoms and you feel that you're getting fobbed off in primary care, keep going back. Keep going back. And I know it's a real pain, you know, and certainly, my cardiomyopathy patients have a direct line into our service, and that's you know, great. But for patients who don't have a direct line in, it's really the squeaky wheel gets the oil, to be honest. And I'm sorry to say that, but that's the nature of our public service now.
Thank you.
With regards to HRT, for women with cardiomyopathy, if they're just given the blanket no, is there any research to point doctors to that says actually this might be safe?
There's not a lot of research, but our party line is that until proven otherwise, there's no reason why a woman with cardiomyopathy can't have HRT. And if you do get a blanket no, you can ask your GP to write to your ICC doctor. I've written letters to say, you know, I've seen your patient. They told me that you don't want to prescribe them HRT. There is no cardiac reason why this patient cannot have HRT. They're having extremely intrusive symptoms of menopause. So by all means, go ahead.
Thank you. Thank you. Yes, thanks.
Thank you. Hi. It's just based on that question, actually. My doctor was absolutely sure that I could have HRT, but wanted to double check with the cardiologist. So I rang, I'm under Bart's, which by the way is fantastic. I inherited cardiac, wonderful. However, the line, and this is only a couple of years ago, was, oh gosh, we've never been asked that question before. And it took about 3 months to finally get somebody to talk to because my GP would not do it until they gave me the okay. And so that to me seems, in this day and age, a little bit weird that there's no basic guidelines at all. Yeah. I mean, are we right? Is that the case?
Yeah, there isn't. But thus far, we've never had any problems with women who have cardiomyopathy being on HRT. And I've had patients come back to clinic and being extremely grateful for being able to go on it because it's horrendous. Yeah.
Hiya.
It's not that quick.
Question.
I've been on
That's me.
HRT for 20 years. I am quite young. But I've basically, sorry if it's a personal question, I've got way too many hormones now. How bad is that for having cardiomyopathy?
I wouldn't be able to comment, if I'm honest, without seeing your blood work and that a bit more detail, I'm afraid. Sorry, not to be helpful.
Are there any?
Yeah, my question's not about HRT. Mind you, I am on HRT and my cardiologist had no problem with, she actually recommended it to me. No, what I wanted to ask you about is, so I've got hypertrophic cardiomyopathy and I got diagnosed with it 9 years ago, but I know I was having symptoms a long, long time before that. So I think probably in my early 30s, I had 2 young children, I had a really busy job and everything, but I started getting what I now know are probably like arrhythmias or something. So you get this kind of and then you kind of feel like you're going to black out. So I thought, right, I'm going to be brave and I'm going to tell the doctor. So I went to the doctor and I said, hello, doctor, who I'm talking to you about, whatever I was talking to you about. And I said, oh, and by the way, I think there might be something that needs to be checked. I get these kind of palpitations and dizzy spells. And the doctor said, oh, you're fine, you're just stressed. So I thought, okay, I'm fine, I'm stressed. So I went and took up yoga, which was great, but didn't change anything. And then 10 years later, it got diagnosed just by fluke, just by a random check, and now I've got an ICD and it's all okay. Is there anything that's being done to educate primary care a little bit more in, as you said, women that are potentially presenting and saying, I've got this, to tell them not to just say, you're a bit stressed, go and do some yoga.
Yeah.
But actually get a stethoscope out or something.
Yeah, I mean, I'll be honest, it's not the first time that I've heard a similar story. It's a work in progress. And I think, I have huge respect for our primary care colleagues and GPs in general. They're up against it, more so than us in secondary care. There's no doubt. We have more time to see our patients, and their job is incredibly difficult trying to work out who needs to be referred and who's got nothing wrong with them. And it is a difficult job. I do, however, also appreciate the fact that there is an attitudinal issue when it comes to women specifically, that actually it's a panic attack or, oh, you're just a bit worried about things. And probably in the vast majority of women that they see, that is probably right. However, if you ever see a woman, as a doctor, if you ever see a woman who's complaining of palpitations and saying they get lightheaded and they feel like they're going to black out, that's a red flag. That should always be referred, in my opinion. And yes, they should also listen to your heart and examine you. So yes, and I think if those things are not being done, keep knocking at the door and don't give up. You've got your ICD, that's great news.
So we've just got time for a couple more. So
it's actually a follow-up to that question. What would you recommend when the doctor is telling you it's probably anxiety, to just follow up and say, and ask, to push them instead of keeping knocking on another door, which might be very difficult? You say okay, but I want you to write in my record that it's anxiety and nothing else. Is there anything that we could do to advocate for ourselves when we're actually in that room and we get stonewalled?
Yeah, I mean, that's a really interesting question, and actually sort of comes down to interpersonal skills, doesn't it? And actually, I don't feel that you should have to really push that hard. I understand that you do. I think it's explaining that how much it's affecting your life, your day-to-day, and that you're really worried about it, and you think that it might be something else, and that you know how you feel, and you know your body, and this doesn't feel normal. And I'd please like to see somebody about it.
Thank you.
Thank you for really informative talk. Actually, as a mother of a 23-year-old girl who I've got ARVC and my kids have been screened, have you thought about going on TikTok with a message? Because I think that devolving information these days, and the young people are doing all this stuff. It's incredible how a message gets across. And you are such a personable young woman, you are young to me, but I think that you could do something really amazing, or one of your colleagues. I just think that's a great way to get a message across around women's health. I don't know if you thought about that, maybe you have, but
Yeah.